of the normal platelet count distribution. Now this is important. Every population, the platelet count depends upon the ethnicity of the people. So if you compare the average platelet count of an American, a German and Indian, so you will find a huge variation in the platelet count. So that's why the WHO defines it as a less than 2.5 lower centile, that is there for that particular population. But in common language, we define it as less than 1.5 lakhs. So any platelet count less than 1.5 lakhs is defined as thrombocytopenia. Now thrombocytopenia is categorized into mild, moderate and severe. Mild be between 1 lakh to 1.5 lakhs, moderate 50,000 to less than 1 lakh. That thrombopoietin secretion, that hormone secretion is basically governed by platelet mass and not by the absolute platelet count. And higher values, we tend to see higher values in females, younger adults and black race. Next important is when to worry about the bleeding. Because every platelet count doesn't mean that the patient is going to bleed immediately. And there are certain red flags. The irony of the situation is that there is a very poor correlation between the platelet count and the bleeding risk. Why am I saying a poor correlation? Because you might have seen in your clinical practice that an ITP patient, immune thrombocytopenia patient, having a platelet count as low as less than 10,000 might be walking in your OPD, sitting comfortably in your chamber and giving no bleeding history symptoms. Neither he is having melena nor any mucosal bleed, no epistaxis, nothing. The patient is perfectly fine, but his platelet count is 4,000, 6,000, 8,000. It might be as low as that. So the correlation, and many a times you see patients of aplastic anemia whose platelet count is 20, 22,000, but they are bleeding profusely to the extent that many a times they develop intracranial bleed also. They need to be admitted in ICU. So there is a very poor correlation between the platelet count and the risk of bleeding. So in addition, there is only platelet count doesn't matter. There is many a times platelet function dysfunction. So you must have seen that a patient being on aspirin, ecosprin, clopidogrel, antiplatelet drugs have a higher tendency to bleed as compared to a patient who are not on these. Similarly, coagulation factor abnormalities like prothrombin time, APTD, they are also deranged in many patients and we tend to miss them, and that is a major driving factor for bleeding in these patients. So in a busy OPD, how can you determine that this patient is going to bleed? That is the most important part which every one of us as a physician do. So first important is ask for the prior episodes of bleeding, and that bleeding should be preferably mucosal bleeding, either melena, that is passage of black colored stools, any epistaxis, bleeding per rectum, or any subconjunctival hemorrhages, mucosal black ulcers in the mouth. So if the patient is giving those history or previous history of bleeding, or the history of wet purpura, that is the mucosal bleed, or any history of hematuria, so these are some of the markers that you should ascertain that this patient is going to be bleed, and he can have serious bleed in form of melena or intracranial bleed, and you should definitely admit this patient in your busy OPD. And so the concept of safe platelet count, as I always say, there is nothing safe platelet count. A platelet less than 10,000 would be safe, and a platelet less than even 20-30,000 would be harmful, and the patient can bleed. So, but there have been certain cutoffs that has been defined by the WHO. So surgical bleeding is not a concern if the platelet count is more than 50,000, except for neurosurgeons, because in neurosurgery and in oncosurgeries we tend to take the platelet count more than 1 lakh. Otherwise, all remaining surgeries, if the platelet count is more than 50,000, then the patient is not going to bleed. Even in neurosurgeries also, now the threshold has been reduced from 1 lakh to 75,000, and many of these patients don't bleed. But still, from the guidelines point of view, a neurosurgeon should be peculiarly more because the neurological bleeds are very sensitive and many a times it lead to serious comorbidities. And severe spontaneous bleeding is rare. It is most likely with the platelet count less than 20,000. And the risk of bleeding also depends upon the cause of platelets. Like aplastic anemia patients bleed a lot. Even at a platelet count of 20,000, 25,000, they tend to have GI bleed. And such a profuse GI bleed that it is difficult to control. And such patients, so the cause of the thrombocytopenia is also important while ascertaining this. Another important aspect is that all low platelets doesn't always predispose to bleeding. Certain thrombocytopenia leads to risk of thrombosis rather than bleeding. So this is important that we should always remember. And what are those conditions? Heparin-induced thrombocytopenia. The platelets are pretty low, less than 10,000, but the patient will present to you with thrombosis, not with bleeding. So you must have never seen a HIT patient presenting as bleeding. They usually present with thrombosis. Similarly, antiphospholipid syndrome, APLA. So another important condition, APLA patients present with a low platelet but with the risk of thrombosis. Many a times you tend to see cerebral thrombosis, mesenteric vein, mesenteric artery thrombosis, and the platelets count are lower than 10,000, and it's a very tricky situation because you fear not to give anticoagulants. Because at a platelet count of less than 10,000, you can't give anticoagulants, so you have to just manage based on the steroid pulses, and maybe you have to put your IR team, involve the IR team to put the filters to prevent dissemination of the clot. DIC, thrombotic microangiopathy, and paroxysmal nocturnal hemoglobinuria. So all these conditions present with thrombocytopenia, but they present with thrombosis, not the bleeding. So causes of thrombocytopenia is very logical. It is one most important cause is the decreased production. When your bone marrow failure is there, the bone marrow is not able to produce platelets. And among these are lot of disorders, deficiency of B12, folate, myelodysplastic syndrome, hematological malignancies, PNH, aplastic anemia. So these are some of the causes when there is decreased production of the platelet. As a result, you are seeing low platelet count. So history is essential, and most important is what all you should take in history and physical examination. So new medicines like quinine, sulfonamides, heparin, alcohol use, physical examination,